Hi, everyone. So welcome. We have another special VMR, and this time with the Cleveland Clinic Internal Medicine program, and we have some amazing residents here to discuss the case. I'm very excited. So to start with some introductions, so we have the team of residents here. I'm going to pass the mic first to, let me see who is closer here. Dr. McGarvey, can you please introduce yourself and then pass the mic to the other residents to introduce them? And we always want to know a little bit about you, but also what you like to do outside of medicine. So thank you and welcome.
Thank you. All right. So I'm Megan McGarvey. I'm one of the associate program directors at the internal medicine program. I did graduate from the program so about 5 years ago, and then started off in primary care and doing a hybrid, and now I'm in hospital medicine. So working today, and we have some really cool cases as well. Am I not answering something that I'm supposed to be answering? Like a fun fact or something, or no?
What do you like to do outside of medicine?
Oh, outside of medicine.
Yeah.
Oh, wow. I used to say go out, but I am pregnant currently. So now it's eating.
Oh, I love that. And what is your favorite food nowadays?
Ooh, good question. God, that's hard. Oh, I'd have to say Mediterranean is like my go-to, but I like pretty much everything. Any type. Yeah.
I love that. Thank you so much. And can you pass the mic to some?
Oh, sorry. Next up, I have Karthik.
Hey all, I'm Karthik. I'm a third-year resident. Originally from California. I've been lived on both sides of the coast, and now in the Midwest in Cleveland. I think medically, I love clinical reasoning. I'm a part of the clinical reasoning conference team with Jason, and we can talk about that later. And then also very interested in critical care, cardiology, and POCUS. Non-medically, I love to travel. So me and my girlfriend try to plan our year out around the trips that we're making throughout the year. So I'm always looking forward to the next place that I'm traveling. So yeah, thanks for having me. We're really excited to be here.
All right, and I'll go ahead next. Hey everyone, I'm Jason Nasser. I'm originally from Lebanon, and I did my med school there, and then I came here to Cleveland Clinic in 2020. I'm a third-year medicine resident, and I'm interested in gastroenterology. And other things that I'm interested in include research and medical education, and I love clinical reasoning, and me and Karthik obviously enjoy doing it back at Cleveland Clinic as part of the team. And in terms of what I like to do outside of work, I think I'll agree, Dr. McGarvey, I'm a big foodie. So I love to cook food and I love to eat food. And I love exploring sort of different cuisines.
Oh, that's amazing. Thank you so much. Do we have any other resident or anyone else to introduce? No? Okay, perfect. So, but before we start, we have Laura. She's a CP Solvers member. She's scribing today. So Laura, can you please introduce yourself?
Hi, everyone. I'm Laura. I'm a fifth-year medical student now. It's the first time I say this, actually. And I'm from Brazil, and today I'm doing scribing only. And yeah, super excited to have you guys here today, and let's do it.
Thank you so much, Laura. We also have Rafa that is organizing those amazing meetings for us. So Rafa, I know everyone knows you, but if you can please introduce yourself, because it's so amazing that you have been organizing those meetings. So I feel that you need more spotlight here.
Oh, thank you so much, Marcela. My name is Rafael, and it's so weird to say I'm a medical attending in Brazil. As with Marcela, we're both applying this season, so it's been like a roller coaster of emotions going through interviews together. It's been really fun. So really excited to be here with you guys. Thank you for coming.
So amazing. Thank you so much, team. So now we can start and jump to the case. Laura, can you please share the whiteboard? And Ravi and let's start.
Okay, so I'm going to kick us off. It's a really cool case. Just a disclaimer. So the way we're going to present this case is that we're going to present it as the case transpired. And so as a medical team, we only kind of picked up the patient, a few hours to a day in their admission. So we'll start off with the patient coming in through the emergency room. So this is a case of a 54-year-old male who presented to the ED with a chief complaint of chest pain. And so our first aliquot information here. So his pain started right before he came into the emergency room. He reported that he was carrying some groceries from his car up a hill to his house, and he experienced sudden onset chest pain associated with some dyspnea. The chest pain is described as mid-sternal, non-radiating chest pain. Otherwise, he didn't have any other lightheadedness, paresthesias, no unilateral weakness or headaches. And that's what we'll give you for now.
Amazing. I think we're jumping right into this. And well, I didn't realize, Jason, that you're a fellow Lebanese. It's so nice to see you here. I think we actually have a couple of people from Lebanon who are in the audience, including Malik, who I just saw is back after a little time. Yeah. My dear friend Laura, I know you're going to hate me for this, but I'm really curious, since I've actually seen you make an infographic for it. What causes of chest pain you reflexively think about as a fifth-year student? Tell us, please.
Rabbi, you make me want to cry.
I know. You're going to hate me someday, and I'm glad it's today. But please tell us, what scary causes of chest pain, maybe that you're experiencing right now, do you think of?
I think because of his age,
Yeah.
I think of probably like the first thing that comes to mind is like cardiac arrest but yeah. Robbie, please don't do this to me.
Perfect. No, I think that's actually right. That's probably what everyone is thinking, right? You have a 54-year-old man who is exerting himself, who has chest pain, dyspnea, and that's mid-sternal. I mean, it's hard to go beyond cardiac. It really is. And I think the approach to these patients in real life is exactly what you said. You don't think about it or go beyond it until you get an EKG. That's what happens to all these people. In fact, in almost every emergency room across the world, I doubt that a physician would see this patient, or any healthcare provider would see this patient before an EKG is obtained. And that just goes to show you that the weight is significantly on the heart. Marcella, anything beyond the heart? Do you think about anything beyond the heart beyond that, or is that really just such a deep anchor that it's hard to move past it?
So I think that the heart is the main thing that comes to mind, because it's so scary, right? Especially when you are in the emergency. But like I was just sending the chat that our schema for chest pain. So you really think like the anatomy, what can be scary and life-threatening causes. So I think about the heart. So we have the 4 causes for the heart, but we also have 2 for pulmonary causes and 2 for esophageal causes that can also be life-threatening. So for pulmonary, for example, we have PE that we need to think about. Esophageal, we can have esophageal rupture or something like that that can also be a lot of concern at this moment in the ER.
100%, absolutely right. Rafa, where you work, I know that you have limited resources. I'm really curious, what would you do if somebody like this came to your ER? What capabilities do you guys have?
Yeah, so thank God we have EKG. So
Yeah,
we do, thankfully. But since this patient is having the chest pain associated with dyspnea, I think the heart and the lung becomes my center of gravity in this case. So I'd be really curious, for example, if I'm thinking about the heart, especially because of, besides the dyspnea, it seems like this patient was carrying groceries. So it was like an exertional activity that led to the chest pain. So I'll be really curious to see if in the past medical history, if this patient has, for example, diabetes, because we know that can increase the risk of having ACS, something that can could elucidate the cause of this problem.
100%.
I'll be basically I will be sending him to ECG and talk to the family what meds he's on, what is past medical history.
Yeah, 100%. I think that, you know, the truth is, right now an EKG is going to be so powerful, and we probably should ask ourselves, how can we get an answer right away? And I think if the EKG shows ST elevations with contralateral depressions, we have an answer. Or if the X-ray, which we can get in 5 minutes, shows a pneumothorax, we'll have an answer. Otherwise, we'll have to think really hard. So I'll just share and emphasize Laura's really practical approach, which is, at the end of the day, the most common cause, the most worrisome cause is acute coronary syndrome. But practically speaking, these patients are assessed in a very practical pathway. What does the EKG and what does the chest X-ray show? And you should know those answers in 5 minutes. And unless the EKG shows a STEMI or the X-ray shows pneumothorax, you have some thinking to do. And since we have about 50 minutes left, I imagine we'll have some thinking to do. So we can already predict the results of those tests, but we'll see exactly what our friends Jason and Karthik have in store for us.
Great, awesome thoughts. I think the differentials that you mentioned are just great. And we're just gonna hold off on showing you the EKG because of its power, one more aliquot. So I'll give you the aliquot of the medical history. As Rafa mentioned, let's look for some hints about what's bringing him into the ED. So in terms of his medical history and medications, he only has mild hypertension. He's not on any medications at home. And his blood pressure usually is around 140 to 90 at home. So he does measure it regularly. He's otherwise perfectly healthy, and because of that, doesn't really follow with physicians. In fact, the last record of him in our system was more than 20 years ago. He has no history of surgeries, none whatsoever. In terms of social history, he's married, sexually active with one partner. For work, he's currently retired, but he's a prior firefighter and a lot of desk jobs, like working for airlines. And then in terms of substance or drug use, he says he occasionally uses CBD, but no other drugs or supplements. He's never smoked. And in terms of alcohol, he stopped 2 months prior, but he only drinks only drinks intermittently, socially. He never drank daily. And then we asked about family history, and he said that he has no family history of cardiac disease whatsoever. His mother had a history of stroke and seizures, and his maternal grandmother had a history of breast cancer. Otherwise, completely negative family history.
Wow, very, very interesting. Yasmin, what does this aliquot do for you in terms of the very mild flavor we have?
Well, after this aliquot, looking at he already has the past medical history of hypertension, but what also gave me an idea is that he was a former firefighter, and people who have this continuous exposure to fires, there's a risk for interstitial pneumonitis due to inhalation, pneumoconiosis, for inhalation of particles that later in life can cause a restrictive pattern of pulmonary disease. So that's something I would also consider in my differentials. Although I don't know how acute or how chronic has these issues of chest pain as dyspnea had been. So and I would use that to know if I keep this on my differential or not, because this tends to be more chronic. Or or also think if this is an acute presentation of a chronic issue. Yeah.
I think that last thing that you said is something that is really sticking with my mind, because at the end of the day, I'm really stuck where Laura's head is how is this not acute coronary syndrome or cardiac disease? And I think we should stay stuck there. But I think we have to now loosen the box with which we probably are locked into for now. And the reason we have to loosen it, I'm not sure who's accidentally unmuted, but let me help them. I've said some very embarrassing things unmuted, so I have a little bit of PTSD when that happens. But let's just think simplistically. Most people who have acute coronary syndrome have underlying CAD. But the truth is that there are other mechanisms to have a problem in the coronary, like coronary dissection. But let's just assume that if we are thinking ACS, we should probably wonder if this patient has underlying CAD. And there are so many reasons to doubt why this patient has underlying coronary artery disease. The first is he's only 54. The second is he doesn't really have any dominant risk factors that are known, recognizing that he's not engaged in care. He has mild hypertension. He has no family history. He has no tobacco use. He has no peripheral arterial disease. And so at the end of the day, his probability of CAD is not as high as you might think it is. So what does that do? It should remind you that CAD can sneak up on people, and the whole conversation about widowmakers is the idea that people can be very, very healthy, but actually have acute plaque rupture of a previously non-significant CAD. In other words, people's plaques can be unstable when they're relatively young, and a young plaque may not cause exertional symptoms, but may rupture. So that's very possible. It's also possible that this patient does not have CAD at all and has non-CAD mediated acute coronary syndrome, such as a coronary artery dissection. But those things are lower in probability than they often are. So what happens? I think you have to ask yourself, what causes in the 4+2+2 mnemonic of chest pain don't have an underlying disease, as Yasmin was saying? PE can develop abruptly. Aortic dissection can develop abruptly. Pneumothorax can develop abruptly. So for me, I'm stuck in the following sentence. The lack of prodromal cardiopulmonary disease slightly loosens the possibility of the most dominant abnormality, acute coronary syndrome. And our potential explanations may be occult CAD, non-CAD mediated acute coronary syndrome, or a disproportionate amount of the spotlight on the non-ACS causes of chest pain that wouldn't otherwise be merited. So in other words, I'm more worried that this patient's going to be trickier than another patient because the story is so concerning and there's a disconnect between the risk factors in the story. All right, we'll pass it back to you all to tell us more.
Awesome, phenomenal thoughts, really phenomenal thoughts. Just to answer one question, yes, it was just acute sudden onset chest pain. He never has ever had any chest pain or dyspnea before. And one thing we also thought of at the time was that because he had not seen a doctor for so long, what if he had developed diabetes in the interim and his A1C is not 15, or he has lipidemia with an LDL 400? We don't have that part of the information, but totally agreed, the risk factors are minimal now. In terms of physical exam, his blood pressure was 108/56 on presentation. His heart rate was 88, respiratory rate was 19. His temperature was 103 degrees Fahrenheit, so he's febrile. He had a 96% saturation on room air. Overall, he looked subdued by illness, but he had an appropriately positive affect. He was ANO ×3. His eyes were normal motion, normal conjunctiva. His mucous membranes were moist. He had no JVD. In terms of cardiac exam, he had regular rate and rhythm. He had an S1, S2, and he had a soft systolic and a soft diastolic murmurs. And they were best heard at the left lower sternal border. In terms of lungs, they were clear to auscultation bilaterally with normal work of breathing. His abdomen was soft, non-tender, and no palpable masses. He had no edema, no joint abnormalities. And in terms of pulses, he had bounding pulses in all of his extremities. In terms of hands, he had no fingernail clubbing. Nails were unremarkable, no lesions, nodes, or other abnormalities. He had no skin rashes, and his neurologic exam was unremarkable with symmetric motor and sensory findings. Does the physical exam change your thought process? Does it add anything that's inconsistent with what we know?
The physical exam explodes my mind. Why? Because I think it's so subtle to notice these abnormalities, and I think it's very commendable to whoever did this exam to really pick them up. Because I guarantee you that if you take this patient and you have 100 people examine them, only a fraction will pick up these very subtle but incredibly important abnormalities. Can I just clarify the vitals? I think I missed them. So the temperature is 103.
Yep. He was febrile, normal heart rate, normal respiratory rate, normal saturation, but he was hypotensive with a blood pressure of 108/56.
Over 56. Okay, gotcha. That's very, very helpful. Marcella, where did your head go with this exam?
Yeah, whoa. So let me see. I'm thinking that he has a fever, which changed a lot, changed a bit our train of thoughts, because, for example, we were focused so much on ACS or something like that. But a fever, now we think more about inflammation or infection. So I'm thinking if maybe he has, for example, pericarditis or endocarditis or something like that. So I'm still thinking of the heart, but now with the fever. And I'm a bit concerned with the low blood pressure. So I want to see the patient overall, if he has like signs of instability or something related to that. So if I am worried with systemic infection or inflammation, and those could explain the heart murmur as well. So for example, endocarditis or something related to that. So I think those are my first thoughts now.
Oh my gosh, I completely agree with you. I think that's absolutely superb. I think because there are 8 aliquots in total, I'll just share my thoughts and then ask Rafa and Yasmin to reflect with more data. I think that the fever is really unexpected and very, very powerful. It makes you wonder how long this has really been going on for and how much subclinical disease this person has been having. And at the end of the day, that's going to be the hard part about this case is to not know when this began. And I think we should recognize that we don't know when this disease process began, and we don't know how long this patient has had a vulnerability for this now new acute disease process, meaning that he could have had a long-standing issue that has let him be so vulnerable for this moment in his life. Now, let me tell you why that's possible. So for that, let's analyze the murmur. So we heard both a soft systolic and diastolic murmur at the left lower sternal border. Now, as a general rule of thumb, you should think of the left lower sternal border as the tricuspid area. However, there's a problem with invoking the tricuspid valve, and the problem is twofold. One, the pulse pressure that you see, which is slightly wide, but more powerful is the bounding pulses that this person had. Now, bounding pulses has a differential diagnosis, and that differential diagnosis is 2 things. Either an appropriately high cardiac output, no different than any of our pulses would be if we had just finished exercising, or aortic regurgitation. In the face of bounding pulses and a murmur, and the fact that the patient has no real reason to have a super high cardiac output, I think we should assume that this person has aortic regurgitation. And the possibilities are that he has aortic regurgitation and that murmur wasn't appreciated and he has separate tricuspid lesion. Or we are starting to hear the vibes of the Austin Flint murmur, which is the radiation of an aortic aortic regurgitation murmur to other parts of the precordium. So for me, this person has aortic regurgitation until proven otherwise. And now why is that concerning? Because fever plus aortic regurgitation is endocarditis until proven otherwise. But why would a 53-year-old otherwise healthy man abruptly get aortic regurgitation or abruptly get endocarditis? And that's where I think you have to think, well, wait, what underlying vulnerability could he have? And I would say the most common underlying vulnerability that exists in people is a bicuspid aortic valve. So could this 53-year-old man have a stenotic bicuspid aortic valve that's causing the systolic component of this murmur, and that now been infected, causing a diastolic decompensation? Now, that hypothesis is low probability, but it's really important to entertain it because of the following reason. When the bicuspid valve is brought into the conversation, the immediate reflex should be on what the status of the aorta is. Why? Because patients with bicuspid valves have an associated aortopathy in a significant percentage of patients. And the reason for that is that the deficit that causes the bicuspid aortic valve has to do with migration of neural crest cells to that area. And that migration also occurs to the aorta, causing an aortopathy. So I'm really worried about this patient. The acuity of the chest pain is very alarming and does not map on very well to the acute development of endocarditis over the course of minutes. So I think you really, really have to be worried about the status of the aorta in this person. Now, why do I say that? I say that because an EKG and a troponin and an X-ray are not going to be enough for this presentation. If I were taking care of this patient honestly, no matter what the EKG showed, I would get a CTA to look for the pulmonary artery and to look for the aorta for that reason. And the reasoning is, again, the following, so it's clear. He has aortic disease and aortic regurgitation until proven otherwise based on the bounding pulses and the no reason to have a high cardiac output and supported by a diastolic murmur. Why would he have aortic regurgitation? Endocarditis. Why would he have an endocarditis of that valve? 53-year-old man, bicuspid. What is a bicuspid associated with? Aortic disease. That's a long chain of reasoning, but it is potentially a life-saving thought analysis that would be very actionable right away. Before we move on, any questions about any of that? I think it's a key pickup by whoever did this exam. Absolutely masterful. I gotta admit, I would give myself a 50-50 chance of picking up these very subtle, especially the murmurs. The bounding pulses, maybe the diastolic murmur. Really good job, whoever did this. Okay, all right, why don't we move on?
Okay. I've seen a lot of these episodes kind of recorded, but it's so awesome to see how these ideas kind of come out live. It's pretty impressive. So we're going to go on to the EKG now. So what I'll do is I'll share my screen and have give you guys a chance to interpret the EKG here.
I think you're the host. You might have to make him co-host. Or so I'm not host, I think.
I already did.
Oh, if it's too hard, we can just tell. We can just.
If not, I could just kind of read out the results. But
I don't see Rafa. I don't see him as co-host. I just see him as, maybe I'm missing it. I'm sorry. There you go. Thank you.
okay.
I see it. Yeah.
Perfect. Okay. So here we go. Are you guys able to see the EKG?
Not yet.
I might just read it for the sake of time. Sorry, Karthik.
Okay, I can read it out then.
Like for your love for
okay.
cardiology, it might be painful to read it out. I'm sorry.
I know. Okay, it's okay. So we have an EKG. The patient is sinus rhythm, and rate is about 175 to 100. Otherwise, the overall kind of the main relevant points from this EKG. So we have ST elevations in leads 2, 3, AVF, and then we have some milder ST depressions in the anterior precordial leads, so like V2, V3, and in the lateral leads, so in 1 and AVL, there are ST depressions as well. So those are the main findings of the EKG.
Rafa, what do you think? Really tricky.
So it's sinus rhythm ST elevation 2, 3 AVF. So it's the inferior heart, right? So it's like a STEMI of the inferior part of the heart. I'm so used to doing step questions that every time I see like an inferior MI, I'm also expecting like a low heart rate, which this patient doesn't have, because we know that it stimulates the vagus nerve.
Yeah.
Okay, and lateral leads as well. Oh wow, so it's inferior and lateral heart is being affected here.
I think you're spot on. You see ST depressions in the inferior, ST elevations in the inferior distribution, and you see reciprocal depressions. The ST elevations alone are insufficient to diagnose a STEMI. You need reciprocal depressions to eliminate the DDX of ST elevations. And so the combination here is virtually diagnostic of an ST elevation myocardial infarction. And to my infectious disease loving CP Solvers team member, Yasmin, how do you incorporate fever in a STEMI?
I would start thinking of any endocarditis process. That's something that stuck with me when I saw this. Maybe this is a new murmur, and any new murmur, we have to think about endocarditis or any other infectious process. Because even if this patient didn't have a medical attention, I would definitely try to look if there is not a infectious process in hard.
I completely agree with you. I think that just to do some fast thinking, because we have a lot of aliquots left. I think if we stay living with the endocarditis hypothesis, you could easily invoke two mechanisms for endocarditis to cause a STEMI. The first is a coronary embolism, so a piece of the pus goes off, and the other is even worse than that. It's a mural abscess. So sometimes you can form an abscess around the aortic valve that occludes the coronary ostia, or the inlet of the coronary. So you can essentially have a compression of an abscess blocking the flow of blood. Those are the two mechanisms by which endocarditis might be happening. However, the STEMI combination with fever should have you analyzing the possibilities, and you might actually have had a STEMI that caused a valvular issue. So a STEMI might have caused, especially in the inferior leads, papillary muscle dysfunction or rupture, which got infected pretty quickly, unusual, or that you have a STEMI and a corresponding VSD. So basically, this person's heart is in a lot of trouble. I think the caution to exercise here is to not rush this patient to the cath lab without a CT angiography. That's the key step here. Because at the end of the day, you have a 53-year-old man with ST elevations, cath lab 90 minutes, right? That's the gold standard. But the fever here, the murmur here, and the possibility of aortic disease should have you do a CTA before you intervene. That would be the practical analysis. All right, tell us more, y'all.
I think those are great points. And I think the ED may have had access to bedside ultrasound that we don't have access to. So the bedside ultrasound may have been reassuring to them, but there was no CTA done before then. So they called it as a STEMI, and he underwent a left heart cath based on the suspicion for an RCA STEMI. His PCI showed that he had 100% occluded RCA distally, and it was a thrombotic occlusion with only focal disease. Otherwise, he only had mild CAD in his other vessels. He underwent thrombectomy, and they put in a stent. His troponins, obviously, we didn't wait for the troponins just to get into the cath lab as fast as possible, but they ended up being 0.7 and peaking at 2.7. So I think, unless you'd like to highlight anything from that, we can give you a bit more information to discuss.
Well, I think you're right. It's really humbling in the ER when you have all this data coming at you to, we're sitting here and we have the privilege of a lot of time. I have seen a patient mount 1 fever in response to an acute plaque rupture. That has happened. We actually got stumped on a podcast case about that. And I think the fact you'd assume that the aorta was visualized as the team was doing the cath, so that may be sufficient. But yeah, I think that the very fact that you have a lot of aliquots left has me concerning. But in real life, you may not be. In real life, you might have had a coronary thrombosis, which has a DDX. But I think now, what I think we can summarize and move on is that this patient likely does not have CAD causing acute coronary syndrome. So we'll have to invoke either coronary thrombosis or coronary embolism, or otherwise undetected diseases on the cath, like coronary anomalous coronaries or things of that nature. But basically, coronary thrombosis or coronary embolism are the leading considerations. And I think the things we're holding in our back pocket are the fever and the murmurs. What are the significance of those? I think are important to hold on to.
Definitely great discussions. So at this point, he got to the coronary ICU where we were, and we took over care. And we reobtained a detailed history because, he had finished his cath. We no longer were on the clock. We had some time to sit down with him and chat even more. On questioning, he noted feeling sick for 2 months with chills and lethargy. At home, he also says that at some point he had an objective fever of 104 degrees Fahrenheit measured. He also reports over the past 2 months he had some myalgias and weight loss, but he thought that the weight loss was intentional because he had been trying to shed a few pounds. We did a full review of systems on him, and those are pretty much the things that came up. Everything else was negative. No urinary symptoms, no respiratory symptoms, no abdominal symptoms. And at this point, we had some labs. His CBC showed some leukocytosis to 12,000. His hemoglobin was 8.2 with an MCV of 82 and an RDW of 13, which is normal, and platelets of 278. His BMP was largely normal. His BUN was 11, creatinine was 0.8, his sodium was 135, his potassium was slightly low at 3.2, his bicarb was 21, his anion gap was 13 before correction, calcium was 8, albumin was 3.2, and phos and mag were normal. In terms of his liver panel, he had some mild elevations with an AST of 56, an ALT of 52, and an alk phos of 106 with a Billy of 0.7. So at this point, how does the extra background info change your thought process?
Marcella, what are you thinking? What does it do for you?
Okay, whoa, so many things happening right now. So I think my main focus right now is that now we have a history that shows that he's having something very chronic. So he had that fever, weight loss, we have some anemia. So it shows that something's happening for quite a while. So infections, I would be thinking about something more chronic. So if it's like an endocarditis, would be from those atypical bugs. Or I'm also thinking about some cancer, for example, that can cause hypercoagulability, and maybe that's why he had this embolism or thrombosis causing the heart attack. Or also some autoimmune conditions that can cause inflammation, and we know that with inflammation we have thrombosis. And I also see that his liver function is also a bit high, so I'm worrying if there are like any embolic phenomenon, if it could be affecting the liver as well. So I think that those are my first thoughts.
Yeah, I love it. Yeah, I completely agree with you. I'm really curious what the blood cultures are going to be, and if not, if there's an underlying malignancy. The MCV is low. It's not quite less than 80, but it does at least make you speculate about whether the source of his possible bacteremia is from the GI and it's from a bug like Enterococcus, which is so notorious for having a subacute and indolent course like he's had. Yeah, I completely agree. Alrighty, you guys want to tell us a little bit more?
So given the chronicity of his symptoms, and he's clearly this paints a picture of inflammation, I think we got a little bit more history, and this is always very interesting here. So we talked about his occasional CBD use, otherwise one dog at home, one sexual partner for multiple years, no other dental work for several years, and then he did have a very interesting travel history. So he did go to South Africa 4 months prior to symptom onset and spent 16 days in Cape Town and Johannesburg. And then he also went to Zimbabwe, didn't have any pre-travel vaccinations, and may have taken some malaria prophylaxis while in Zimbabwe. We don't know which specific medications. And then 2 months prior to his presentation, he did go to Jamaica, and then was in Las Vegas earlier in the year as well. So those are some of the travel history that we get from talking to him.
Yes,
how does this change your thoughts? Do you feel like this is a red herring? Do you feel like this is going to help you make a diagnosis? What do you think, Yasmin?
Okay, so right now, before they said about the travel history, I was thinking, well, where is this patient located? Because there are infectious diseases that can actually cause bacterial embolism. That's something that I was putting in the chat. And then I was thinking, then with his past history of having traveled to Africa or to a tropical area, I may think a vector-borne disease, although I'm not very sure if it's because of a fly or a mosquito. I would have to look for this flea disease. Fly disease. I just trying to pinpoint it. But I am going more to an infectious disease. I still have that thought.
Yeah, no, I think it's hard not to, right, with this very enticing travel history. And at the end of the day, you have to be rooted in the fact that if this is if the infection we're thinking of, which is probably infectious endocarditis, given the fact that there's fever and heart issues, the vast majority of them are stuff that lives on our skin, right? Like staph, strep, and enterococcus. And so you take your skin everywhere you go. So it could be completely independent of the travel. But as you said, there are some exotic ways to get endocarditis, and those are usually culture negative, like Bartonella, which comes in a couple of flavors, and Brucella. So here, I think what I'd be really, really curious about is whether brucellosis or Q fever, which is another zoonotic transmission, are at play. But at the end of the day, I think this travel history is only a distractor unless his blood cultures are negative, because you take your skin everywhere you go. And so staph, strep, and enterococcus also went to South Africa, Zimbabwe, Jamaica, and Las Vegas. So we'll see if they're at play, or whether we have to expand to the exogenous diseases that you were thinking about, Yasmin.
Awesome. So we can just jump into the labs. And so his lactate was normal. In terms of risk factors for CAD, his lipid panel was normal. His A1C was normal. His urinalysis had 1+ protein and RBCs. His urine toxicology was was only positive for things that he was given in the hospital. Otherwise, it was negative because there was a bit of a delay in obtaining it. His CRP was 13 elevated. His ESR was 60 elevated. In terms of anemia workup, his ferritin was 700. His iron and TIBC were both low with a saturation of 9%. His haptoglobin was normal at 259. His LDH was 281, slightly elevated, and his Zaret-Coombs was negative. We did some infectious workup, things that are easy to rule out. An acute and remote hepatitis panels were negative. His HIV test was negative. He had an ANA positivity. We thought this was before we didn't want to fixate on an infection. We wanted to slightly broaden it also to autoimmune. His ANA was positive 1 to 160, but none of the other antibodies were positive. So it was only ANA. And then we may not have mentioned it, I'm not sure, chest x-ray was negative. And then we did a bedside POCUS on arrival, and we found that he had significant aortic insufficiency with thickened valves. And then to move things slightly along, we wanted to rule out malaria. So we got a blood parasite panel because we wanted to make sure he didn't have two separate things going on with anemia and the fevers. And it was negative for blood parasites and plasmodium. And then we obtained blood cultures and they were flagged positive for Enterococcus faecalis. So you put the patient on zinc and ampicillin. And then we got an echo, which showed 1 to 2 plus MR with thickening and a small echodense structure attached on the anterior mitral valve. And there was torrential aortic valve regurgitation, 4+, with echogenic filamentous highly mobile structures, with the largest being 1.7 centimeters by 0.5 centimeters. And then there was no patent foramen ovale. And then we got per ID's request, we got a full body CT, again, by virtue of the things that you pointed out, what if he's embolizing to the liver? And then his CT brain, chest, abdomen, pelvis were all really unremarkable for abscesses or myocardic aneurysms. And unless you want to comment before we give the, I suppose now clear final diagnosis. So we finally diagnosed with this person with an RCA STEMI due to a coronary artery embolism from large aortic valve and mitral valve vegetations from subacute infective endocarditis of his native valves.
Wow, absolutely humbling. Well, we definitely would love for your reflections on being part of this case, or at least learning about it. I'm curious. I just saw that Shema is here and been scribing away. Shema, what stuck with you? What did you take away from this experience?
Well, because I was scribing, I didn't focus so much, but
That's okay.
no, what it tells me is, I mean, seeing that he has both vegetations on 2 valves.
Yeah, right.
I would have, I was surprised seeing that he also has the mitral vegetation. So I'm asking myself, did he have some underlying aortic valve issue, what you mentioned with the bicuspid valve, and then he had some superimposed issue on the mitral valve? Because, yeah, that's really for me.
Yeah,
but
no,
yeah,
same. I'm actually wondering the same thing. Why did this happen to this person? And why did it happen to 2 valves? And unfortunately, in many cases of enterococcus fecalis, the answer is it happens to people. We worry about colon cancer as the source, and we worry about a diseased valve as the vulnerability, but it's not uncommon that neither of those questions have a definitive answer. But I'm curious, from Karthik and Jason, what your overall reflections are on this case, and if you know the answers to those questions, let us know, please.
Yeah, those are all really great questions. A lot of those questions we don't have answers for, unfortunately. But I could just tell you how the case kind of resolved. So he underwent cardiac surgery. He had replacement of the aortic valve, repair of the mitral valve. He ended up having a single vessel bypass and with removal of the RCA stent. And they actually found pus at the site of the stent placement. He was treated with 6 weeks of IV ampicillin and ceftriaxone. And then the only kind of thing that he was noted to have post-op was some evidence of AV dissociation. So he had a second-degree AV block, but he remained asymptomatic throughout that. So yeah, so those are all very great questions. I think overall our workup did not reveal a source of the infection. So we are just postulating that it's GI or GE source, but no definitive answers to how the pathogen was introduced into his bloodstream. And no reason as to why he had endocarditis to begin with the normal native valves, no bicuspid valves like Robbie was saying. The other kind of thing that we were looking at was something that you guys had mentioned, was that given that he had no prior coronary artery disease, it should kind of prick up your ears as to coronary thrombosis instead of the traditional way that we see with STEMIs is being a plaque rupture. Other take-home points, so coronary embolic events are unusual presentations of endocarditis. Literature is showing only about 2% of cases in infective endocarditis. And then they only account for about 5%, less than 5% of all coronary embolic events, the most common being patients with AFib embolizing a left atrial clot. Other take-home points, I think we had multiple red herrings in this case. You know, the most obvious being the travel history. I think we can go into very long discussions about all the sorts of pathogens that he's at risk for traveling in South Africa and Zimbabwe, but it ended up just being something as banal as enterococcus. And then just along the similar vein, we kind of discussed that it's important to question pieces that don't fit with your overall illness script. And I think all of you guys did a great job of doing that throughout the case presentation. So we're happy to answer any other questions about the case before we move on.
I'm just really humbled. And I think the point you just made, Karthik, is a really important one. I think the vast majority of people who come in with acute coronary syndrome have too many risk factors for CAD, way too many. So it's often not even something that you calculate, honestly. And so it really sets it up for a good mental exercise to be like, well, what happens if somebody comes in with chest pain and they don't have risk factors for CAD? And I think you have to think occult CAD. It may be a lesion that is actually bypassed or a clinically insignificant plaque. It may be a non-CAD mechanism of ACS, including coronary embolism, or it may be the other causes of sinister chest pain. And I think that vacuum, the lack of CAD risk factors today, was filled by a coronary embolus. Another day it might be filled by occult CAD, and another day it may be filled by an aortic dissection. But it's really important to hold all those three thoughts, which you might not otherwise hold in a patient who has prominent risk factors and comes in with a story like that. You don't need to hold them. Really, really amazing case. Marcella, what did you think? I'll let you reflect on your thoughts on the case and then transition us to the other parts of this gathering that you had planned.
Thank you so much, Robbie. Well, it was an amazing case. I learned so much. And I love it how when you were discussing his vital signs and the physical exam, how you were we started discussing endocarditis and also the aortic insufficiency. So that was my favorite part. So now moving on, I would love to know if the audience has any questions about the program. And I was wondering if to start, I would love to know from the residents and from Dr. McGarvey, what are your favorite things about the Cleveland Clinic Internal Medicine program?
Dr. McGarvey, you can
There's
start.
so many. No, I'm just gonna be like all went silent. Okay, my favorite thing is the diversity of experience that people bring when they come here. I think that because it's a hospital system that accepts so many people like as patients from around the world. Part of the ethos is also that we accept like providers from all over the world. And I think it's really, really incredible what happens when people from everywhere kind of come together and are able to pick each other's brains, much like what is happening during this very like Zoom meeting. So it's very cool. I love working with the residents. I think a lot of our like curriculum includes residents in it. So like I work on clinical reasoning, and Karthik and Jason work with me and also with a big team. So we have about like 30 people that kind of take turns coming in and out. So those are my personal favorite things, but I'll let them kind of say what they like.
Yeah, I can talk a little bit. I think one of the things that we note is that our program is very large, but I think the program does a really good job of making it feel smaller. And so as a result, we are a really close-knit group of residents. I think the resident class is probably the biggest strength of the program. Two, I think for people that are interested in med ed and being involved in academia, there's lots of opportunities. And so I'm part of the clinician educator track at our program. So I've been giving a lot of opportunities to help develop curriculum and shape how the program runs. And so I think those are the two things that I can think of right off the top of my head.
And for me, I definitely agree with what was said. I love that the environment is like really collegial. It's very supportive amongst residents, like between each other and between staff and residents. You also really feel it. And there's a lot of like diversity in culture and background in between the residents. There is really no strong preference about taking a specific area or location. We come from all around the world, really, as a collective group. And some of my favorite things also include the wealth of patients, that we have such diversity of patients. There are some people who are at Cleveland Clinic by virtue of being like a safety net when they don't have insurance at all. And some of them are there by virtue of traveling across states or even countries just to come over. And just the diversity and complexity of cases that we see is just really impressive. And I just enjoy going through them.
Thank you so much. I love the answers. I think Yasmin has a question. Yasmin, can you unmute yourself and ask your question?
Of course, this is mainly for residents, but how is a day on call like? Like what kind of backup supervision or things you have to do normally?
So on call, I think we recently restructured call. Previously, we used to do some 28-hour calls, but we realized that it's really hard to be sure to be within the ACGME limits of hours, and we wanted to protect residents as much as possible. So, and by virtue of how big the program is, we were able to split call between day and night. So a lot of our call shifts are really night shifts and then versus day shifts. So it's been an enjoyable experience, and night call is every other night, not every single night, which is also pretty nice because you get a significant time off. And in terms of supervision, I'd say there's always a lot of resources available at the hospital. We have phenomenal fellows that are always accessible and always on call. So there's always that safety of you have someone who's smarter than you at that specific thing to ask. And also we love discussing things amongst each other. So the person who's covering cardiology floors at night, we'll talk to the person covering oncology floors at night. We'll talk to the person who's covering medicine floors at night. And we often sit in the same room sometimes at night. So it's nice.
Thank you so much. And Rafa also has a question.
Yeah, I was wondering if you guys could talk a little bit about what you do for fun in Cleveland between residents.
Yeah, we have a big group of people, but we always try to coordinate with each other when we go out. So there are lots of options for food and drinks. And then one of the things that we love is the Metro Park. So unexpectedly, I think Cleveland has lots of outdoor activities to do. So whether it's hiking or kayaking or places to hang out outside. So I think those are the things I like to do most. And then also hang out with friends in our own homes, cooking and just passing the time, I think. So Jason, anything else you want to add?
Just because I mentioned earlier that I was in New York. For now, honestly, like a lot of restaurants in Cleveland are just so accessible and they're just so good. They're really above average, like really far above average, but they're just so accessible because I don't know, there's not necessarily like a lot of hype, etc. So it's nice to be able to go to like the best restaurant in town and have phenomenal food and not worry about having a reservation and it being, very cost friendly. I'm a foodie, so I really like that aspect. And there are a lot of fun cultural things to do in Cleveland. The museum is massive and it's actually really good. And they do like nights of the museums and events there. So that's always nice. And there's a lot of art and culture scene. So if you're interested in that aspect as well, you'll have a lot to do.
Thank you so much. I was also wondering about education opportunities in the program. I saw that Karthik mentioned about the clinician educator, and I would love to know more about those education opportunities.
Yes. So the clinician educator track is a track that you have to match into when you're applying for the program. But the opportunities aren't just restricted to the residents in the track. So specifically through the track, most of us have a project that we're working on. So one of the projects that I'm working on with a few of my co-residents who aren't in the track is trying to develop a simulation curriculum for codes and acute clinical scenarios. So in the past, we've had curriculum for telemedicine, which became especially relevant during the pandemic. And then one of our co-track members developed a POCUS curriculum before he left the program, before he graduated. So those are some of the opportunities for residents in the track. But like, Dr. McGurvey is saying, we have a really big team for the Clinical Reasoning Conference. And so we have the opportunity to develop conferences and then facilitate as well. And then there's a curriculum committee. So anyone that's interested in proposing a new curriculum idea can present there, and then we'll be given the tools to help develop the curriculum and then evaluate it eventually.
Yeah, that sounds amazing. Thank you. And I believe Yasmin has another question, and I think to respect our time, that is going to be the last question. Yasmin, can you please unmute yourself?
Of course, yeah, I think I have lots of questions today. But for example, how often is feedback provided, and where do you think you learn the most in this program? What do you think that it's something that your program has that has helped you like learn the most?
So in terms of feedback, it's very staff dependent, but I think a lot of us have like learned to be proactive about asking for it. And you have a lot of meetings with your advisor, so there's always some feedback that goes through that channel as well. But you do get a good amount of feedback, and especially in certain like floors more than others in a way. And in terms of where do we learn the most, I feel like I learned the most from the patients themselves, because really like the kind of patients we often end up seeing have such complexity that they're at the bottom of the guidelines algorithm. And by virtue of like getting there, you have to know what's before. So you end up learning a lot just by going through every case. And staff usually are often good about giving us autonomy to think through things ourselves. Karthik, do you have another perspective?
No, I think I echo pretty similar sentiments. I think the best feedback is one that you ask for and that you are very proactive about. And it's feedback that you get immediately. So I think that's the kind of feedback that we value the most. And then like Jason was saying, I think when we learn the most is on the wards with the complexity of the patients. I think it's, I think after graduating, 3 years of residency here, some of the things that seem really, crazy to see are very rare in other institutions, are things that we see quite routinely here. So, we'll rarely get a patient coming in with one issue. It's an issue with 10 kind of comorbid conditions in the background. So we've gotten pretty good at trying to piece through lots of information and figure out what's the most important for us when taking care of the patients. So I think the complexity of the patients is the strongest point of our program.
And I know we're out of time, but it would be amiss if I don't answer Hamshah's question in terms of research. Research is definitely available, and it's definitely one of the strengths of our program. And you can honestly just see that objectively by looking at conference attendance and the number of abstracts that residents end up putting there, just the resident presence at conferences and the number of publications residents put out. And the program can give you some research time off, and there is a research track if you want 4 months of research sort of back to back. So definitely research is a big strength. And yes, I think there are opportunities for medical students to rotate. Okay, I'll stop.
There are, but there's been a lot. I mean, I'm not gonna lie, like it's been really challenging for a lot of people to get their rotations, especially with COVID. Like it was basically shut down for a really long time. It's back up, but it's very limited. So I'm not even gonna lie about that. I know I've had so many people reach out kind of begging for observerships because unfortunately Jason wasn't really allowed to go or able have the time to go into it, but that's how a lot of the residents ended up kind of getting letters and getting experiences. So I know, for international grads, you have a whole huge I don't know, challenges that you have to go through and different hoops you have to jump through. So it is definitely a challenge.
But yeah, definitely. Yeah.
Oh, sorry, go
Thank you
ahead.
so much. No, just wanted to echo that. Yes, definitely try to get some away electives wherever possible. But yeah, otherwise.
Yeah, thank you so much. And as an IMG, I know how hard it is, and I appreciate the honesty. And we had a lot of challenges during COVID, so yeah, it's not easy. So thank you so much for answering all the questions. I really appreciate and also the amazing case, the discussion, talking about the program. So the CP Silvers family, thank you all. And just to finish, if Dr. McGurvey could say some final words about the program, something that you would like to highlight just for us to close. Thank you.
Sure. I think the biggest thing I'll highlight is how awesome our residents are, Karthik and Jason. People get super involved in things, and it's the best part of my job. And I think, people get along pretty well. So pretty down to earth place, which I appreciate. Other than that, I appreciate all of you guys too. This is awesome. And that's about it.
Thank you so much. Bye-bye. See you all.
Thank you for having us.
Thank you so much for having us. Bye-bye.